Thank you for the opportunity. So I'm going to talk on FACO KDB versus FACO Bang. So MIGS is one that is up and coming, and this study is about comparing the early outcomes of two such excisional goniotomy devices. One is KDB, which is made for this particular purpose, and other one is the bent ab internoneedle goniectomy, which is called the Bang with 25 and 27 gauge needle. So the purpose of it is to include mild and moderate POAGs who are currently under AGMs, and the primary outcomes were reduction in number of intraocular pressure from baseline pre-op versus post-op, number of anti-glaucoma medications, how many had greater than 1 AGM bottle reduction with medication-free population with complete and qualified success as secondary outcomes. And the World Glaucoma Guidelines of complete success, qualified success, and failure was actually followed. And the methodology was a prospective comparative study done with all consenting consecutive patients during the 6-month period, with 71 patients being included in the study for a follow-up of another 6 months. And they were graded based on the Humphreys or the Octopus Visual Field as mild or moderate POAGs. And based on the logistics, especially economics involved, 32 patients choose KDB and 39 went into the Bang procedure for a combined phacoemulsification with cataract. And this is an open label study with both the patients and researcher being aware. And along with gonioscopy and anterion was also done at 6 months follow-up to see the post-angle dynamics of this particular study. So this is a short depiction of the Cahook dual blade procedure where the KDB blade was actually used to excise the goniotomy, as you can see here. And if there was a remnant trabecular meshwork that is hanging, an ILM peeling forceps was used to release it. And this was the bent ab interno needle goniectomy procedure where the 26 gauge needle was used to perform the same, but it was not made for it. So the pair t-test was used to evaluate, and this is the FACO KDB group. IOP from 22, it came down to 16, you can see here, and this is the reduction in number of AGM from 1.16 to 0.62, along with greater than 1 AGM and medication-free population, with a complete success rate of 72%. And in the Bang, you can see from 20 to 15, more or less the same. And the AGM reduction was also from 1 to 0.49, 1.07, with medication-free population only being 50% at 6 months, and the complete success being 48. So let's see a quick comparison here. The path chosen is different, but they have a common destination in reducing the intraocular pressure. Similarly, in terms of IOP as well, where KDB had a slight edge, and the reduction in number of AGM also was quite similar. But here, if you see the greater than 1 bottle reduction and the number of percentage of bottles or medication-free population, they seem to be slightly better in the KDB group, and these are the demographics of the study. And complication profile, there were few microemphysema in the KDB group, whereas with Bang, there were few patients who had some choroidal folds with no hypotony, and there was one patient having an emphysema which was quite lasting 1 week, and 2 patients developed peripheral anterior synechiae. So these are some of the post-op images of the Bang. And then the anterior images gave a clear-cut picture of a W sign, whereas in Bang you can see there was some remnant of trabecular meshwork leaflet that was there. So both the procedures reduced effectively the IOP. In patients whom KDB was performed, the IOP was comparable to the Bang, while the decrease in the number of AGM was also comparable, but post-operatively, the medication-free patients were higher in the KDB group, and KDB group achieved a complete success of 72% and maintains a total success of 87, whereas Bang was able to maintain only 48 and 74, and the failure rate was double that of the KDB group. That is because of the remnant leaflet theory. Have a look at this particular theory, which is what presumably could have happened. A KDB blade is actually quite smooth, and just like scooping a vanilla ice cream, it completely scoops the trabecular meshwork with a clear W sign, whereas with Bang, we tend to have few leaflet remnants because it doesn't have the dual blade and the ramp to really scoop it off. So there are few remnants of trabecular meshwork which can serve as a precursor for PAS. Literature in KDB is there, whereas Bang is quite new, and that also supports this study. And there is few adjacent trauma that can happen with the Bang, which is very minimal with KDB, where there is a surrounding tissue injury. That is why you can see a clear W sign in a KDB, and these are some of the pictures of the same. So to conclude, my dear friends, FACO KDB versus FACO Bang, though both are excisional, provided a comparable IOP and AGM reduction, but the failure rate with this bent ab interno needle goniectomy, the frugal needle that we are using, seem to cause some additive surrounding injury where it can go in for a failure quite early compared to the Bang. And the proportion of the eyes able to reduce 1 or more AGM while maintaining the IOP less than or equal to 21 appear to be eyes in the eyes undergoing KDB slightly superior to Bang. So there are some limitations. We need to have more RCTs, and these are the future directions. Thank you for the opportunity once again for giving me this opportunity.
Because most of the people may not know it.
Yes, sir.
Just shown at least one picture, although your study is very well done and
Yes, sir.
conducted. Of course, it's a open sort of, you didn't do anything where we could...
Sir, MIGS is something that is very upcoming, sir. We have the stenting devices as well and the excision devices. So there was a video where KDB is having a Kahoot dual blade which lifts the trabecular meshwork and then scoops it off. Whereas with the bent aventino needle goniectomy, a frugal innovation, the Rexis needle that we use, we bend it the other way around and then we try to do the same. It's a frugal version of KDB. So, but KDB seems to be superior in terms of tissue injury as well as tissue recovery, which is very important for angle surgery especially. At early outcomes are coming that both are equivalent, or it looks like it's equal in terms of IOP and AGM. But the catch here is the ability to reduce the intraocular pressure. The number of failure rates are slightly higher with BANG, and it's very upcoming, sir. With more data, more follow-up and multicentric trials, we'll be able to, yes, sir. Thank you, sir.
Excuse me,
It was a 4-1.
Pardon me, sir.
It was a foregone conclusion only because of the adequate removal of trabecular meshwork in KDB and just a goniectomy in BANG. So all the things were, I think, right from the word go, once you show the video, we were hoping that KDB would definitely do better. It was a foregone conclusion for me at least.
Sir, in glaucoma armamentarium, sir, ASOCT is there and UBM is there. So this novelty here again is anterion, sir, because anterion was never used to visualize the post angle in a MIGS surgery. So
No. My question is that because KDB ensures complete excision,
yes, sir.
obviously success rate will be more and failure rate will be less.
So, but
No.
BANG has also been highlighted in the
Yeah,
market
I know.
as it's a similar.
no, but
to,
tell me what the instruments that you use for the BANG is a needle, which is also a type of needle that you can make yourself, or
yes, sir.
or
BANG,
or you it's an ordinary 26 gauge needle which you can make yourself.
it's a
Whereas the KDP one is a special device, isn't it?
yes, sir.
Which is a very costly device.
So cost wise depends, sir.
Which is
because-
a very costly device because I mean the success, if the bank success is much better than the KDP and the cost is much more, what do you think will be the future of this?
So there is, in excision at least, if you are taking MIGS and excisional goniotomy, KDB seems to be superior to BANG. But if you're looking at cost effectiveness, there is another one that is coming into the armamentarium called as suture GAT. Suture gonioscopy assisted transluminal trabeculectomy, where you use only a 5-0 suture, where you open up the canal from inside. So for cost, logistics and other thing, the stenting was sounding more, so we went into this BANG. Now we are moving into sutures where the suture is being threaded and that is being opening the canal from inside out. So these are some cost alternative options, sir. KDB is costly, but it is not as costly as a stenting device. Yes, sir.
So, but the intraocular pressure reduction in all these cases, is how many, with all these procedures, about 5 to 6 millimeters or more than that?
Sir, these are all mild to moderate POAG patients. I have not used severe POAGs. I have not used angle closure POAGs. So if you are going to enhance the spectrum into angle closures where we do goniosynocular followed by an angle surgery, as well as if you go for severe POAGs, then you may have a much drop in intraocular pressure as well. Because
These are all open angle cases.
all open angle and all mild to moderate cases only, sir. Yeah. Thank you.
Thank you, Dr.